All attendees are in listen-only mode.
Welcome, everyone, and thank you for joining us today for our webinar on EMS Is Evolving, Are You? Today's webinar is co-sponsored by Page, Wolfberg & Wirth, and TriTech Software Systems. I am honored to introduce our very respected colleague and friend at PWW, Steve Wirth. Most of you, if not all of you, are very familiar with him already. Steve is an attorney and founding partner of Page, Wolfberg & Wirth, and you can read his full bio on the PWW website. My name is Kelly Watchell, and I'm the training supervisor at TriTech. Just a reminder that today's webinar has been approved for one NAAC CATCO CEU, that's the Certified Ambulance Compliance Officer. The CEU certificate will be included in the follow-up email along with a link to today's recording. Although everyone's mics have been muted so that we have a good audio quality for today's presentation, we do strongly encourage you to ask your questions through the GoToWebinar dashboard at any time during today's presentation. We'll answer as many questions as we can following Steve's presentation. If you experience any audio quality issues on the mic and speaker option, please switch to the telephone option and dial in to the number provided in your GoTo dashboard. And with that, we'll go ahead and turn it over to Steve. Welcome, Steve.
Thanks, Ella. It's great to be here this afternoon with all the friends of TriTech out there around the country. I guess we have a great turnout today. And it's really great to be here from downtown Hampton Township, Pennsylvania, near Mechanicsburg. And we're getting some of those storms you all got in the Midwest. So hopefully we won't have any power problems today. But we're excited to be here and talking about a very interesting topic that we've been dealing with here in the last year, and that certainly we all need to pay attention to, and that is, what does the future hold for EMS, and what are some of the issues and problems, and how do we deal with them? I thought it was interesting today that the folks at TriTech sent me a list of attendees with questions in terms of what are your top issues. Well, I scanned through that list of all the top issues that people identified, and pretty much here we'll certainly have time for questions at the end. So just a couple quick announcements from our end. We have our spring conference series, ABC3, our last and not least program for the spring is coming up in the next few weeks at beautiful Clearwater Beach, June 7th through 11th. So you still have time to sign up if you'd like to participate. We have a whole range of programs. We have our full ABC3 conference, which is the most popular and the most well-attended ambulance billing and compliance conference in the country, that 2-day conference, and then we have our 1-day executive institute, and then we have the National Academy of Ambulance Compliance, NAC, running 3 certification programs during that same time: our Certified Ambulance Coder program, our Certified Ambulance Compliance Officer program, and the newest program.
I'm sorry to interrupt, Steve. This is Sherry, and we are experiencing some audio issues. So could I ask you to dial in over that phone number that you wrote down earlier? I think that might help. You'll need to switch to your telephone source under audio and dial into that phone number.
Okay.
Sorry about that, but I'm afraid it's going to continue. And while Steve does that, just to provide a little bit of background here, once we get so many hundreds of people logging in, we never know how it's going to load the system. So usually when we have a telephone as opposed to a mic and speakers, that'll resolve any audio issues. So if you can just give him a few minutes to do that, we'll get back started with this presentation. Thank you for your patience.
Great time maybe to submit some of those questions that you've been thinking over as EMS is evolving, or questions that you might have for Steve. Throughout the presentation, again, you can feel free to submit those questions, and then we'll take as many as we can at the end. The GoTo dashboard is commonly on the right side of your screen, and there's a questions section there. And this is, again, a great time to maybe be logging those questions so that we can get to them near the end of the session, or maybe it's something that Steve will even touch on then during the presentation. While Steve is dealing with some inclement weather out east, we are definitely reveling in some beautiful weather here.
Okay, can you hear me now?
Welcome back, Steve.
Well, thank you. Can you hear me okay?
Yes, it's much clearer. Thank you.
Okay, great, good. Okay, great. Sorry about the delay, folks. We'll move right along here. And just wanted to remind everybody again about our programs coming up. And let me just make sure I get to the right control here. And don't forget Hershey coming up this fall, October 17th to 21st. So mark the dates. The agenda is out, going to be out very shortly. All new content, all new agenda. I think everybody's going to be happy with our program we have planned for you this fall. So mark the dates for fall Hershey ABC3 along with our certification programs through NAC and our Executive Institute program. Also, we want to point out we have the ABC Quick Guide available now, ICD-10 ready, complete with crosswalk from the ambulance condition codes over to ICD-10, and that's so those things are flying off the shelves, so you can order those as soon as you can. They're now available. You can order them on our website. The information is provided there as well. This is our standard warning sign that everybody's familiar with. This material is copyrighted. Please don't record it. It's being recorded separately. And, of course, any information we provide today is simply for educational purposes. No attorney-client relationship is formed here by the use of these materials or participation in this seminar. Lawyers speak there. If you have any specific questions about your agency, want to talk to us, reach out to us separately offline. We appreciate that. Okay, very good. So we got the approvals. We're good to go. Any questions you have today, the best way to do that is to go to the GoToWebinar control panel and to ask your questions there, and we will try to get to as many of those as we can at the end. Or you can fax them in here too if you want to, but it's probably better to stick with the control panel if you can. That's the easiest way to do that. So a quick overview of what we're going to cover today is, first of all, I want to touch upon the new healthcare landscape and what we're all faced with today in this world of healthcare reform. Talk a little bit about the top 5 evolutionary challenges that we see for EMS into the future, and then wrap it up with sort of our 3 visions for the future and steps on how to be ready for these changes that are coming upon us today. Well, this slide sort of says it all, and this is the Institute of Healthcare Improvement's triple aim of healthcare. And this is the core basis of healthcare reform. The whole focus in our healthcare system is to really look at the 3 prongs of this triangle and work to improve these 3 areas. As many of you know, our healthcare system is a good system. We have great access, but it has problems. It's very expensive. Patients always haven't been as satisfied with our healthcare system. And there's a real question about, are we doing things that actually improve the health of the population, and are we doing that in a cost-effective way? So the goal here of the triple aim is to improve population health. So that ties right into EMS because we're out there in the community. We're talking about community paramedic programs. We're out there in the community providing public health services. We're more than just ambulance transportation. We're more than just EMS. And the whole shift is moving healthcare outside the 4 walls of the hospital. So that means greater focus on health in the community, increasing or improving population health. Of course, we want to do that in a cost-effective way, and the goal of the triple aim is to reduce the per capita cost, what it costs per head to provide services, healthcare services, and we are very expensive. There's no question about it. Healthcare costs have gone through the roof over the last 20, 30 years, and the goal here is to try to do that, provide healthcare services at a reasonable cost, and ultimately to improve the experience of care for the patient. This is not just dealing with improved outcomes, it's also satisfaction. Of course, we want improved outcomes. We want to see people getting better, and that's the goal. Part of this whole approach to healthcare reform is that the healthcare payers, like Medicare, Medicaid, and commercial insurers only want to pay for things that actually make a difference in people's lives. Does it really help improve their health? We also want to make sure they're satisfied with that care. And this is an area, I think, in EMS that we've been somewhat inadequate in terms of assessing the experience of care that our patients have. And I think this is going to be something that's going to really help us in terms of determining what changes we need to make within each of our EMS agencies. We all know the legacy model, and that is you pay for the services provided rather than improving the health of the patient. That's an unsustainable model. And what we've seen over the years is payments based on numbers of services or frequency of services that have been provided. And there's really been no incentive to improve quality when you think about it. You can go to a hospital where someone does, say, 10 cardiac caths a month, and then you go to a major medical center where the doctor there does, 200 of those a month and does them better than the doctor who only does them a few times. Bottom line is they're both going to get paid pretty much the same. There's no distinction in terms of quality and outcomes here in terms of payment. So that is a major culprit in our system. And poor providers getting the same reimbursement as good providers, that's going to change under this new AAA model of providing health care in this era of healthcare reform. Now, to put it more in context, our healthcare system, as we said, is in fact the most expensive in the world. Of all nations, it is number one in terms of expense. 17% of our gross domestic product goes to healthcare, and ironically, we have among the poorest outcomes in terms of outcome measures in the world with respect to developed nations. And when you look at it further, you look at lifespan. We're not at the top, folks. In fact, Iceland is at the top, number one in terms of life expectancy. I guess it's a low-stress place to live, and they have excellent health care and all that. But the U.S. ranks about number 20 of developed nations in terms of life expectancy. And mortality rates are higher as well. So people are looking at this and saying, we got to really do some changes here to make our system work a little bit better, more efficient, and ultimately improve the outcomes of the patients that we serve. So that's the model that we're faced with here. Now, the new model, the Affordable Care Act, or Obamacare, whatever you want to call it, has been, this whole concept of healthcare reform has been around for a while. We've had healthcare reform going on for 10 or 15 years, and so it isn't just Obamacare that is the root of these changes. We've seen these changes coming. The focus is placing a greater emphasis on quality and outcomes as the road to payment. Pay for performance, pay for measurement. Healthcare getting paid or penalized based on the quality of care and the outcomes. And we just saw a recent announcement from the federal government that they're shifting a significant amount of payment under the Medicare program to this pay for performance or quality of care and outcomes approach to reimbursement. And we're going to see they set some pretty lofty goals in terms of shifting over, and I don't think EMS and the ambulance industry is going to be high on the list in terms of that shift, but it is coming, folks. It is definitely coming our direction, and that's what this article points out. This just came out a few months ago. Their goal is to have 85% of provider payments under the current fee-for-service system, which we're paid under, to shift over to value-based purchasing, value of care reimbursement rather than by volume. So that's really what it comes down to. The other aspect of healthcare reform in terms of quality is this whole concept of transparency. And that's a very important concept. Hospitals have been wrestling with this for years in terms of, do they keep quiet their infection rates, their error rates, and things like that? Well, the lid is pretty well blown off of that one, folks, in the last 10 years. Hospital there's measurements of hospital infection rates, and there's hospital inpatient quality reporting measurements now. There's 72 quality measurements that are being used. You can look at this website, Hospital Compare, to see what some of those are and how your hospital's ranked. Bottom line is consumers have the right to know how good is the care at that hospital, just as they have the right to know how good is the care by their local ambulance service or EMS agency. So we're seeing lots of changes. Data is all over the place now. You know that in this past year, CMS published ambulance data in terms of payment data based on 2012 numbers. So you literally can look up your competitors. You can look at the county next to you and see what that ambulance service charged based on the HCPCS code, level of service that was charged. You can look to see how much they were reimbursed under each of those codes. So it's pretty much an open picture. Now, that's just 2012 data. That's going to be expanded in the years to come. Okay, quality metrics. Well, we don't have too many of them, folks. As you all know, the ultimate metric is response time. Response time criteria. A lot of municipal contracts are based on that. And we all know that speed is not the main indicator of success in EMS in terms of, as well as in terms of positive outcomes to the patient. We know that speed can often kill, especially if the ambulance is racing to the scene and hits somebody, or is racing back to the hospital with a patient. And there aren't too many times where speed is of the essence. There are a few, like STEMI patients, getting them to a cath lab. We can measure that. We can measure how long it takes to put an EKG on a cardiac patient. So that's another quality metric that can be measured. But there's a lot of initiatives out there right now. Compass program is being led by the National EMS Officers, State EMS Officers Group, and with NITS involved, to look to provide better quality metrics so that we can do a better job of measuring the outcomes of what we do. And also in the area of patient satisfaction. That's an area, as we said, that's been very weak, and we need to do a better job of it. Bottom line is, as Mr. Deming said many years ago, if you don't measure it, you can't manage it, you can't control it, you can't improve it. And ultimately, at the end of the day, you do lose money if you can't do these things. So we really got to come up with systems that do a better job of measuring these quality metrics, allowing us to have a better management system in place so that we can monitor or review that data and make appropriate changes. We've got to have control over the system, and we've got to look to improving the outcomes, improving the level of service that we provide for our patients. And the bottom line is that quality is everyone's responsibility, and that is another key phrase you're going to hear in the coming years. We've got to drive this throughout the organization. It can't just be people at the top speaking about quality. It's got to be people bought in at the front line, where the rubber meets the road, where the ambulance wheels turn, and where the dispatchers answer the call. Everybody has to have an equal commitment to quality, because that's ultimately going to drive efficiency and basically going to drive patient satisfaction, positive outcomes, and hopefully improve our reimbursement at the end of the day as well. So there's going to be lots of opportunities for those who develop effective quality metrics. They're going to have a huge leg up as we move forward. So getting everyone educated about this triple aim of healthcare, as we showed you in the earlier chart there, you get them involved in it now, it's going to prepare you for the reimbursement changes that do appear to be inevitable. We are already seeing major changes. Healthcare reform has brought about the advent of high deductible commercial plans. We're having to wrestle with that, trying to get paid, a real challenge. And those who are staying ahead of the curve here and staying up to speed in what's happening in the healthcare sector, generally speaking, are going to have the leg up. And I think that's an area we can all improve upon, and that is reading about, taking a look at what other areas of healthcare are doing to address and to deal with these changes that healthcare reform is bringing upon us. So the top 5 EMS evolutionary challenges that we see going forward here, we'll run through those. Number 1 is increased government enforcement. That is an absolute fact. We are seeing a tremendous increase in the number of audits and investigations, and bottom line is the government is paying closer attention to the Medicare trust fund, the Medicaid money, etc. So we really need to focus on that. There's been a huge crackdown on alleged billing fraud and abuse in the system. And unfortunately, these kinds of initiatives sort of rope us all into that category in a way. Unfortunately, we deal with a lot of different government agencies and government investigators and U.S. attorneys' offices, and it's a shame, but they sometimes have a tainted view, a negatively tainted view of our industry, and that's because of a few bad apples that create that image for us. The vast majority do a wonderful job, and we're fighting to keep the money that you obtain in reimbursement for the appropriate level, appropriate services that you provide. But a lot of these definitions of medical necessity and things of that sort are vague, and reasonable minds can differ, so that's where we sometimes get into disputes with the government over this stuff. And they are really putting in an unprecedented amount of resources into fighting Medicare fraud. And for good reason, because they found that it's one of the most efficient things they can do. The federal government, for every dollar they spend on healthcare fraud fighting efforts, they bring back $8 into the Medicare trust fund. That's huge. Where can you get a return on investment, 8 times the dollar you put in? And they're seeing that as a benefit, so they're pouring more money, more millions of dollars into hiring new investigators, new U.S. attorneys, assisting U.S. attorneys, OIG agents, and enforcing and putting more money into the Medicare contracts for the Medicare administrative contractors and other contractors to administer and to initiate more of these fraud-fighting efforts. And, of course, we have state governments now involved. We've been very busy with numerous Medicaid audits and investigations around the country. And it wasn't that long ago where states really didn't do much auditing of Medicaid funds, and now they have to under the law, under the Affordable Care Act. So these are the things that we're seeing. Commercial insurers are teaming up with enforcement agencies. They're getting together, sharing information, and of course we've got private whistleblowers who have more protection now under the laws, and there are more attorneys out there doing this plaintiff side key TAM cases, these whistleblower cases. And of course, we're on the defense side of that picture, and we're dealing with a lot more of these law firms that are out to, they get a contingency fee. They generally get 30% or 40% of what the whistleblower ends up getting in the settlement. Some of these settlements for private whistleblowers have been to the tune of several $1 million. So not a bad fee if you represent a whistleblower. So bottom line is, it's more important than ever to do things properly in today's enforcement climate. You've got to make sure you got your I's dotted and your T's crossed. And at the end of the day, you want to keep that legitimate revenue that you've earned for the hard services you've provided. And that's why you got to spend some money on this stuff up front. So it is a lot about prevention. And unfortunately, in a lot of agencies, we see things like the training budget, compliance budget getting cut rather than expanded, and precisely the opposite is what needs to happen here to adequately fight this government onslaught against healthcare fraud and abuse. So increased government enforcement is challenge 1. Challenge 2 is a shortage of competent and compassionate staff. That's a big issue. I saw that pop up in a number of responses today. We really got a dilemma here. We got 2 population bubbles moving through the age cohorts here of our population. We have those like in my category, and maybe some of you out there who are baby boomers born before 1964 and before. We're moving out. We're getting to that cusp of retirement. Okay, some have retired already. There's a range there, about 15 years or so. And baby boomers are moving out. That creates 2 dilemmas. Number 1, we're losing our leadership. Our senior, most experienced people in our EMS systems are moving out and retiring. What are we doing to train those new folks? What are we doing to mentor those new millennials who are moving up through the ranks? The second problem with the baby boomers moving out of our EMS agencies is that we're going to become patients too. We're part of that growing burden of elderly people in terms of being in need of health care. So we have this massive population boom going up through over the age of 65 now. In the next 20 years or so, you're going to see, the biggest number of people alive in this country are going to be people over the age of 65. So it's a huge dilemma for our healthcare system. That means we're going to get busier. Now, that can be a good thing. EMS agencies are going to get busier. Those who are staying ahead of the curve here and getting involved in things like community paramedicine, you're going to make out well because you're going to see the road here to success. The other population bubble is we have millennials moving up. Okay, those are the folks in their mid-20s to early 30s now who are a big population group, and they're moving up. Now, what are we doing to train them? What are we doing to pass on the institutional memory to them from our EMS agency, and how to do things compassionately and in a caring way? We hear that phrase, these kids today, they're just so caught up in their computers and their smartphones, they don't even know how to talk to people. Well, I hear that, but you know what? I see older people doing the same thing. We have older people involved in their smartphones as well. So we really got to look at bringing our millennials up and mentoring them and getting them ready to take our place as we leave our organizations. Inadequacy of our basic training programs. We don't focus enough on these quality issues, like good communication skills, like being empathetic, like being caring, like being compassionate. And then on top of that, we get a shortage of quality supervisors and mentors. We have supervisors who don't want to mentor people, and the people at the top of our organizations need to make sure that that is a fundamental responsibility of being a supervisor. And we see far too many supervisors who look the other way when they see bad behavior. Or they look the other way when they see good behavior, and they don't compliment someone when they should. So occasionally, the example I used just recently, I had a supervisor say to me that all he does is babysit the schedule. I said, what do you mean by that? He says, my job as a supervisor, all I ever do is try to find people who come in and fill the spots. Well, if that's what you see your role as, you're not going to be interacting very positively with your people. And we really need to focus more on training our supervisors and middle management people to do a better job of connecting and communicating with the frontline staff. That's a key point. And when you do that, I think you're going to encourage more people. They're going to want to come to your organization. They're going to want to be a part of a positive organization. And we are suffering from this present shock, the human response to living in a world where everything's instantaneous, where everything's supposed to happen now, as Douglas Rushkoff said. So we have to deal with that, and we have to make sure that people see the bigger picture and see how things like being empathetic and caring and compassionate are essential qualities that we need to see in our field providers. So we have to have competent and compassionate staff, and those folks are the ones who are going to be compliance-oriented. They're going to be focused on compliance and doing things right. Okay? All right, challenge 3, the declining traditional reimbursement situation we have. Healthcare reform is shifting to paying for services based on effectiveness and outcomes, okay? We talked about that a little bit. We've seen reductions, everything from sequestration about 2 years ago. We had fractional mileage come into play a couple years ago. That reduced some of our reimbursement. The annual inflation increases that keep getting, that ball keeps getting kicked down the field every couple of years. And elimination of those bonus payments, we've seen that threat loom. We managed to salvage it here for another couple of years, and then we got the dialysis cuts from last year. So lots of things under the current fee-for-service model that are negatively affecting us. So we're going to need to work to look at other alternatives. The other challenge here is the traditional healthcare delivery model is changing. This requires new thinking. Now, I throw this little slide in here about the fire service. Everybody knows this, 150 years of tradition, unimpeded by progress. Everyone's heard that phrase. We tend to be steeped in history and tradition. And there's nothing wrong with that. That's important. We can't let that get in the way of progress. We need to look outside of our own organization to come up with new ideas and better ways of doing things. And this applies not just to the fire service, but to EMS as well. We see the same problem in our EMS agencies around the country. We tend to be a little too close-knit, and we tend not to sometimes look outside our own organization and not thinking out of the box. We're moving from a transportation commodity to mobile integrated healthcare, is another way to say it. And unfortunately, the current legacy model pays only when you transport somebody. Well, that's counterintuitive to this whole concept of healthcare reform, of getting people well out into the community and helping them stay out of the hospital. You call EMS and the only way they get paid is if you transport them? That's counterproductive. Well, that's the problem, and that's why we're seeing community paramedicine programs come into play. We're seeing federal grants to support those initiatives. The Reno, Nevada program I was just reading about again, we know the folks there. There's many of them around the country where grants have been awarded to put together programs that improve patient outcomes, reduce hospital readmissions, and keep people out of the hospital who don't need to be there. So we're really shifting from emergency medical services to out-of-hospital disease management. And those agencies that sort of get the picture there and see that shift are the ones that are going to succeed. And we've seen shifting of public-based and private-based systems. Some communities are moving EMS into fire. Some communities are moving EMS out of fire and contracting it out. It's a real mix. And people ask us, you know, which way is it headed? Well, it depends on the community. Every community is different, and we can't say that we see it moving one particular way or the other. So it's all a matter of community needs, and that's what the focus is when we look at modeling our systems today. And, you know, this famous phrase that Mencken said, when they say it's not about the money, it is about the money. Well, we know that. We know there's hospitals out there that get into things like cardiac caths and other things. Do you think they do it solely for the reason of helping their community and the patients they serve? Well, no. They also see it because of the reimbursement that it brings. So, yeah, there is money behind a lot of motivation in healthcare, no question about it. And that's something we also have to factor in here. And the competition has really changed. It used to be a big competition between the public and private sector EMS agencies, you know, and, you know, who should do this? Should EMS be based at the fire department or should it be privatized, et cetera, et cetera? Well, okay, we've managed to grow through that, and we realize that every community is different. Now we're seeing, you know, competition not at that level, but between EMS and the ambulance service and other community health care providers like visiting nurse associations, home health agencies who want to get a piece of the pie of this new community paramedic concept. And that's we're seeing some additional competition there. So these new competitors you got to be thinking about, and that means you got to retool how you approach your marketing efforts, how you approach your relationships within the community. You've got to get in touch with these folks. Sometimes it's best to stay in touch with your competitors, see where you can work things out together, particularly your hospitals. You need to communicate with them. You need to be meeting with your hospital CEOs and seeing where you could fit into the puzzle and into the mix here of healthcare reform into the future. And the fifth trend we see is the need to prove our value to the payers and our community. With the increase in that we've seen with transparency in healthcare, we're seeing a shift in terms of what the public expects. They have been accustomed to this traditional EMS model that they see on TV from back in the days of emergency, even back then to the early 1970s. But what we're seeing is a shift here. We're seeing more education. We're seeing more attention being focused on community paramedicine. And we're seeing the public saying, hey, you guys can do more out there in the field. And pretty much we're seeing more scrutiny over what all public entities do. Funding challenges means all public services are coming under greater scrutiny for effectiveness and efficiency, so that's a challenge. But with that challenge brings a lot of opportunity, and we see a lot of opportunity coming to those who are ready to rise up to the challenge and you know, hang in there and be willing to change and be willing to look at new ways of delivering EMS into the future. And as they say, success depends on your perspective. You know, some people are pessimistic and tend to see the glass half empty. Others tend to see it half full. And that's, you know, it's always better to see things half full, I guess. Allows you to have the motivation to move on and to view things from sort of the bigger picture. I thought this was a cute slide in terms of, you know, looking at something differently than you normally do. So that's what it's all about. And when we look at the state of the EMS nation today, we have the Affordable Care Act that has now literally insured millions of additional people. And that's a good thing. We're seeing more people insured, presumably meaning some additional reimbursement, although we could debate that one for sure. We've seen Medicaid expansion in most states. That has taken people who didn't have any insurance or any Medicaid coverage and expanded their coverage. So hopefully, given, of course, we have generally woefully inadequate ambulance rates under Medicaid programs, but something's better than nothing, I guess you could say. We have the insurance mandate, minimum essential coverage, conventional insurance. We have high deductible plans that we're dealing with, and we're seeing an increase in Medicare and Medicaid Managed Care. So these are some of the areas that dealing with the insurance realm that we're experiencing under the Affordable Care Act here in the last couple of years, and that we're going to see into the future. And I alluded to this earlier, but the aging population means an increased need for EMS. With 80 million people hitting retirement age in the next 15 years, that can't help but bring us more business, so to speak. Older people use medical transportation more often than younger people, and that increased utilization will lead to more revenue. You may not be seeing it yet, and there are other factors that hurt your revenue stream, but we are going to see that, and that that's why you're seeing people invest in healthcare organizations. That's why there is investment in the EMS sector from outside equity firms, because they're looking into the future. They're futurists. They're saying, hey, wait a minute, we can't help but go wrong. We can't, go wrong here by investing in healthcare, because more people are going to need healthcare. People are getting older. They're going to get sicker, and that's what some of these folks are seeing. So we need to look at that. And we're really poised for success. As our friend Dr. Greg Margolis said a couple of years ago at a conference, I liked how he said this. We are really poised for success when you think about it. We provide health services 24/7. A lot of healthcare entities do not. We're community-based. We're integrated into the community. We do the chicken barbecues. We run the bingo. We have the open houses. We're out there talking to people. We respond in vehicles going into their homes. We're mobile. We've got the capability of moving our people and equipment, and we're highly reliable. We have a mindset based on practice guidelines and protocols and checklists and things like that. That leads to efficiencies, and we have the training and experience to do these things out in the community. So we really are poised for success into the future under this new realm. And I can't think of any other healthcare service that's more deployable than EMS. There is not. And that's a huge advantage as healthcare is being pushed out into the community in the coming years. Okay, so let's talk about our vision a little bit here before we get into some of the questions. We're going to cover three visions. One is that we see tremendous opportunities for growth in the age of healthcare reform. But that means you have to, in order to thrive, you've got to be able to adapt to the changing reimbursement sources and to modify your deployment accordingly. And third, those who induce a culture of compliance into their organization are going to be the ones that really survive and thrive, particularly survive in this government scrutiny. So that's really what we see as the vision into the future. So the first one, opportunities for growth in the age of healthcare reform. There's going to be a lot of opportunities here as we become more integrated into the healthcare community. And that's another positive side of healthcare reform has been we're meeting with hospital administrators. We're meeting with other healthcare providers. We are providing services that others see as valuable now. We used to just be those people you called and you needed to haul somebody to the hospital. We're now beyond that, hopefully, in our communities. We're more visible. And we're seeing, again, the drivers behind this being the societal changes, the aging population, and the changes in the law. The Affordable Care Act is driving a lot of this, and other laws that have come into play as well. So these are the driving factors. And we've certainly seen how this readmission aspect really has been, this readmission penalty aspect of the Affordable Care Act has really shaken things up in terms of the hospital world. The Affordable Care Act penalizes hospitals for excessive readmissions within 30 days of discharge. That's a pretty significant number, 3% of Medicare payments in 2015. And that's just not penalizing for the fees charged for those particular patients. It's all the Medicare reimbursement. So the penalty goes beyond a penalty just based on the Medicare reimbursement received per patient who was inappropriately readmitted. So the goal here is to monitor patients for compliance and make sure they don't need to come back. Okay, that's really the ultimate. And the money, penalties for readmissions, will also drive hospitals' concerns about what happens to the patient after discharge. So now all of a sudden, hospitals are much more concerned about what happens to the patient when they get pushed down the hallway in the wheelchair, out the back door, or out the front door. They want to know, because they don't want this patient coming back. They want to make sure the patient follows their care plan. They want to make sure they take their medication. Because if it's one of these areas where penalties are going to be assessed, it's going to cost them greatly. And you know, the dilemma in this whole thing is this excellent quote from Health Leaders magazine in 2012. The problem is patients can't get to the doctor, they can't afford or don't fill their prescriptions, they get confused about their dosages, or they forget they must change their routines. Their anxiety or loneliness or unexpected drug reaction prompts them to call 911, oblivious to household hazards they suffer a fall. And that's, you know, sort of the quagmire. This is what we all see out there on the street. You see anxious people in the middle of the night. They don't know what to do. They're out of medication. They got no one to help them. They're anxious. They're lonely. They call EMS because we're there. We're in the community. We're easy. We respond. You just dial this number and we're there within a few minutes, okay? And unfortunately, you know, part of the problem here is they get confused. They fall in their homes, and then someone finds them or whatever. And this is the dilemma that we're dealing with, and how to best manage this typical patient situation that we're seeing today. So in terms of action points on what you can do to take steps here to address this, number one, assess your current market and your future market potential. See what you can be doing in your community. What does the community need? You know, community paramedicine is a great thing, but you know, you can't just cookie cutter it and go to a conference and plug in somebody else's model and expect it to work in your community. You got to assess your community and see what the market is for these services and how will they be provided. Because community paramedicine can vary from community to community to community, and you need to make sure it's tailored to the needs of your community. Secondly, you want to get a handle on your costs. You cannot make any meaningful changes, positive changes, unless you know what it costs to turn the wheel on an ambulance. You need to conduct a comprehensive cost analysis, mainly for business reasons, to make sure you understand what your costs are. And once you understand those costs, you can look within those costs to see where you can adjust and move accordingly to try to reduce costs. It's also important in the era of compliance, because government investigators are really cracking down on the anti-kickback statute. They're going after ambulance companies and hospitals who are engaged in improper pricing practices for medical transportation services, okay? So if you're giving your hospital trips for free practically, or at a greatly reduced cost that's below the cost of providing that service in return for getting all that Part B business that they can give you, that violates the federal anti-kickback statute, and the government is getting much more aggressive on that. And the third point is to meet with hospitals and other customers. You need to get out there. The CEO, the chief, the main job of that person should be the face of the organization, getting out there, visiting Rotary clubs, Kiwanis clubs, other organizations, speaking to whoever that will listen to you, and talking about your services and what you provide and what you can provide for the community. And that's really an essential aspect of success in the future. Exploring other revenue streams, looking at charging for non-transport services, looking at other means of fundraising, looking at things like membership subscription programs, looking at various crowdsourcing fundraising efforts, okay? There's lots of that going on now, and it's amazing what people are willing to contribute to through the internet. So look at some of the other revenue streams, and granted, these streams aren't opening up as quickly as we would like, but we got to really search out for them. Look at grants and other opportunities to expand your community paramedic programs. Fifth, engage your governing body, and you've got to meet with your elected officials. You need to be comfortable with them. They need to be comfortable with you. Your staff need to know what's going on so they can be folks who are out there beating the drum as well in favor of your organization. And you got to meet with the public so you know what they need and to let them know what you're doing. and maybe you do a community strategic plan. I've seen various EMS agencies do that, where they bring in various stakeholders throughout the community to help develop a plan, a strategic plan for what they want to see their ambulance service do into the future. Getting organized at the state level to make sure that we are considered in new laws and legislation that occurs, absolutely essential. We haven't done a good enough job of that. Some states are better at it than others, and some states just don't have a very organized ambulance association or EMS association. But it's absolutely essential. You know, these big insurance companies, they're well organized. You know, the laws are going to be in their favor unless we're in there fighting for our place at the table as well. So that's very, very important. The second vision that we see here is to thrive, you have to adapt to the changing reimbursement sources and ultimately modify your deployment. We know that traditional Medicare is flat or reduced. We know that Medicare and Medicaid Managed Care programs are rising, so we've got new challenges there and a fight to keep the costs down. Medicaid roles are rising. More people are being covered under Medicaid. Now that can help you, but if you're in a state where you're not getting paid a whole lot, you need to be working to increase those rates to try to make the most out of this change. But of course, in some areas, you know, getting something is better than nothing. We have insurance exchanges. We have more people covered, getting essential benefit programs. We have accountable care organizations also in delivering care. So we've got various sources of payment and shifts in those payment sources that we're seeing under healthcare reform. The paradigm shift, yes, 911 service volume has been increasing, but a lot of it is becoming more non-emergent stuff. The non-emergency service aspect of EMS has been exploding. Medicare has noticed this in the last 10 years when they look at payment. The greatest increase in payments out of the Medicare Trust Fund have been for non-emergent type transports. And that's consistent with what we're seeing with the shift in society with the aging population that we just talked about. Payment for non-transport services is the way of the future, and looking at a wide range of other types of things that you can charge for, these home visits, you know, community paramedicine programs. Hospitals are willing to pay you a flat rate. They're willing to pay you a per visit fee. Patients, there's a lot of areas in the community where patients are willing to pay a subscription fee just to have someone come by and check up on their elderly relative once or twice a week. We can be a part of that. So these are ways of expanding our source of revenue. And we need to shift our staffing models to address the new economic realities of what's happening out there. That may mean a shift away from the traditional 12-hour, 16-hour, 24-hour shift model and focusing more resources during particular times of day at shorter intervals. So that's something to think about. Dynamic deployment, making sure that we match call demand to the resources, getting the right vehicles with the right crew, the properly trained, the level of certification that they need, that the patient needs, the right patient at the right time. That's what it's all about. Lots of many advanced technologies and computer modeling out there that can help in predicting where calls may be and the types of calls. We're just seeing tremendous advances in dashboard computer technologies. First Watch has been making major inroads there in terms of being able to monitor your system real time, live, to see what it's doing and where you need to adjust and dynamically deploy units, okay? The day is coming, folks, as you know, that when the call to 911 will not always get you an ambulance. You'll get a call first with a nurse navigator or someone like that, a clinical expert who will direct you to the other modes of health service when the ambulance is not needed or necessary, because healthcare is all going to be integrated. We've seen a lot of cities making tremendous strides in integrating healthcare. City of Houston Fire Department has been involved in projects where they have iPads out there where they do FaceTime with the doctor at the scene and talking to the patient and sometimes scheduling the patient for an appointment the next day rather than taking them by ambulance. These are the kinds of things that we're going to see happening as we become more integrated into the healthcare community. educating the public. You know, it's an emergency vehicle, not a taxi. Well, then if you're a progressive EMS agency, you're going to have other types of vehicles, okay? So educating the public as to when 911 should be called and when they should not be called is another important aspect of this. Can we do this now? Yes, we can. Call intake is the front door to the healthcare system, and 911, or the number that they dial for their ambulance service in their community, is the way of accessing healthcare for many people. And we can manage this. We can do it in a way to improve reimbursement so that we don't waste precious resources. We can improve efficiency, reduce people's stress, improve patient care as a result of making sure we're getting the right vehicle with the right crew to the right patient at the right time. So, key to survival here is knowing your payer mix and trends. Very important. You need to know where the money's coming from and where it's going and where you see it changing into the future. Establishing KPIs, key performance indicators, and other metrics for each area of the business, not just response time, but other areas of operation, clinical indicators, as well as reimbursement efficiency indicators, whole bunches of things we can talk about here. Monitor, communicate, and improve performance based on evidence. You've heard the phrase evidence-based medicine. Well, far too often, you know, you go to an EMS conference and you see all the gadgets and all the lights and the bright things and all the new toys, and everybody loves it, you know, when they go up to the exhibit hall. Do these things actually work? Is there research upon which these products are based? Those are the kinds of things we need to be looking at. We should only be making changes when the evidence shows that change will make a difference in people's lives. So we want to engage technology and people sense to adjust our deployment strategies as needed as well. So those are some action points. Look at all your cost centers and your lines of service. What works, what doesn't work, what's profitable, what's not profitable, and getting input from all levels of the organization, including the frontline staff. They tend to be sometimes the last people we talk to, when they should be the first people we talk to. Get out there, ride with them. Just ride along as a third person and watch and listen and take notes. I mean, you can learn so much by just doing that, because these are folks that are out there, you know, experiencing the initial calls. They're experiencing the patients in their worst situations. Sit in the dispatch center. Sit at a console. See what kind of calls they get and how difficult it is to deal with callers when they call in. And take a look at your call intake and dispatch protocols and how you go about quizzing patients when they call in. Consider improving those protocols and doing more training so that we get more information at the time of the call so that we can better direct the patient to the right service. The last vision here is absolutely essential, and it's probably the most important aspect of healthcare reform and our success in this new arena into the future, and that is we have to foster a culture of compliance throughout our organizations. That is absolutely essential to surviving government scrutiny and surviving all these changes with healthcare reform. We absolutely have to do that. And when you look at all the different laws, and here's just a slide showing all the different compliance laws over the last 15 or 20 years, there's a plethora of these things that are affecting what we do every day. So we really got to focus on compliance, because focusing on compliance definitely pays off. You don't want to be part of a $49.2 million fraud case. These are the kinds of things and headlines that we're seeing, that we're sending out on our bulletins and listserv. You know, it's every day we're seeing a new example of where the government has taken down an ambulance service or ambulance operators and so forth. And it's not just the private sector. We're seeing it across the board, private for-profits, private nonprofits, as well as government-operated ambulance services as well. So, you know, all entities are subject to the power of the government here, and the Affordable Care Act has really strengthened the government's ability to pursue fraud and abuse. It means you can no longer pay lip service to compliance. We've run into so many people over the years where they talk big about compliance, but they don't put their money where their mouth is, and they don't really walk the talk, and they don't really set an example for their staff. And if you're in a leadership position, it's an absolutely imperative thing to do. And All of this is impacting all levels of our organization, from billing to field personnel. Documentation, I saw a lot of comments on documentation. We just ran our ICD-10 webinar series, the last webinar on documentation, had a huge turnout. You need to tune up your documentation. We're available to help. We've got things coming on the horizon to help with that, some additional products and services, and we're always available to help you do on-site. We can do on-site documentation training for you to help tune this important area up to the level where it needs to be. Operations and levels of response, dispatch, and call intake, these are all areas where compliance can impact your organization. One big change a few years ago was the 60-day overpayment refund obligation. Some people still don't understand that. Once you identify an overpayment, and you do have an obligation under the Medicare law to assess the payments that have been given to you to make sure they're proper. And if they're not proper, you can't just keep the money. You got to send it back within 60 days. And if you don't, it becomes a false claim. And the government can go after that under the so-called reverse false claims act theory, retention of an overpayment, improperly retained net overpayment. Mandatory compliance programs are on the horizon. That's part of the Affordable Care Act. Nursing homes are going to be first, of course, with a lot of aspects of the Affordable Care Act. It's been delayed. But yes, the Affordable Care Act is going to require all healthcare entities to have mandatory compliance programs. Joint strike forces in those hotbeds for fraud. We've seen there's 9 of these strike forces now. They're expanding them around the country. And, City of Houston, City of Philadelphia, and the greater areas around those cities, they were the first to experience the power of the government in issuing a moratoria on new ambulance services. It's rather telling when the first time the government exercised their authority to initiate a moratorium, they target the ambulance industry. So that goes to show you how much focus they're putting on the ambulance industry. Provider screening. Wow, we haven't been doing a good enough job here. We're seeing folks within our agencies who have been excluded from participating in Medicare, so we need to make sure our individual providers, EMTs and paramedics, are currently certified, that they are not on the list of excluded individuals and entities. We need to do regular background checks and so forth. And Medicare is more thoroughly screening providers before they can get a provider number, a Medicare provider number. And they found, it's very interesting, it tells you how bad the fraud must be out there in the Medicare world when you look at some of the statistics, and they say that like 25 to 40% of the fraud can be stopped simply by doing a revalidation visit, because just by visiting to make sure there is in fact a healthcare entity there with a provider number cuts down on the fraud. They found so many places where entities have provider numbers and have been billing Medicare, and yet they go there and there's nothing there. It's an empty storefront. And, talk about the epitome of fraud. So, if the government can catch a lot of the fraudsters just through increased provider screening, well, they're going to continue that, no doubt about it. And we already mentioned the moratoria. So, creating the right culture, failure to invest up front in preventive steps that could have avoided compliance problems in the first place often ends up costing you much more, many times over, when a major compliance issue finally bubbles to the surface months or even years after it should have been detected. You know the signs and symptoms. We're experts in the field of determining patients' problems based on signs and symptoms and assessments. We need to do these signs and symptoms and assessments internally within our own organizations. We can detect where we have problems. We can look at signature compliance, what percentage of the calls are we getting a valid patient signature? Are they using the exceptions properly? Are we getting crew members to review each other's run reports and sign off on them? You should be. Do we have a good system in place for checking clinical documentation based upon specific standards that need to be met for each particular type of patient condition? Are they covering all the bases? If they're assessing a patient with abdominal pain, do they go through the documentation of the onset of the pain, the quality of that pain, the severity of that pain, the radiation of that pain, the OPQRS key mnemonic, those kinds of things. These are the things we need to be doing. Medicare auditors and reviewers are really clamping down on being very critical of our clinical documentation on our patient care reports. So we really need to focus on that in the coming months and into the years ahead. Creating the right culture is all about preventing problems in the first place and then having a system to detect an anomaly, detect a problem when we see it, when the system's off kilter, and then a system to correct it, and then it's one big circle going back through prevention, detection, and correction once again. And that's really what the culture of compliance is all about. So set the right expectations. In the hiring process, focus on hiring people with compassion and empathy toward other human beings. Put that in the job description. Make sure documentation is an essential job function of an EMT or a paramedic. And communicate those expectations to your folks initially, when they get interviewed, to when they get oriented, and throughout their employment experience. Implement an active compliance plan, not something you just buy from us and put on a shelf. Make it a working, living, breathing document. Implement clear compliance policies that are enforced and that all your supervisors are in touch with and that they understand how they should be applied. Conducting internal and external audits. We need to be doing that. Monitoring and promptly refunding overpayments. We talked about that. Training dispatch, billing, and field staff on all aspects of compliance, and really working to shift the whole mindset of your organization from a reactive mode to a proactive mode. And that really demands accountability at all levels. Accountability is a key aspect of healthcare. Healthcare is all about collaboration and individual accountability and working as a team. And we need to make sure that everybody understands that compliance issues must be addressed, and that anything that's improper, that's unethical or illegal, must be stopped in its tracks. And that's why we want to implement anonymous reporting systems as well, because sometimes people are uncomfortable going to their boss, and we need to give them another channel. We want them to come to us anonymously rather than go to the government talking about all the illegal things that they claim to be happening at your agency. Appoint a chief compliance officer and integrate quality assurance or quality improvement in compliance at the front line. Get the frontline staff to take ownership and have responsibility for it. Leadership and compliance, they go hand in hand because it's no longer a see no evil world. Everything is transparent these days in healthcare, and it's going to continue to become more transparent. So those who are seeing these changes, who understand this new healthcare landscape, and they understand the challenges that it brings, they're the ones who are going to be well suited to adapt and change into the future. And there are many opportunities out there. We just need to take the initiative, be creative and willing to change, and try some of these new things and see if they work. If they don't, go on to something else. Okay? Go on and try something different. All right. Well, let's see. You can still purchase all 3 of our webinar recordings to add to your training arsenal on ICD-10 for the ambulance industry, implementation, coding, and documentation. You can order them on our website, quick guide. Of course, we also mentioned. And, again, we can help you with your training needs as they arise, particularly in this new era of compliance that we're all faced with today. And if you're not already on our bulletin list, you can sign up for our bulletins. And we'll keep you in touch with what's going on. One of the things people had said in the comments in the survey today was just staying in touch with the constantly evolving world of reimbursement and compliance. And that's what we try to do for everyone out there in the EMS and ambulance industry. So with that, I think we're ready to open it up for any questions here. You guys, we toss it back to Kelly, I guess.
Yeah, there are a few that have come in, and we'll give you a chance there to take a look at those.
Okay, you're able to hear me okay? You're able to hear me
you.
okay, right? Good,
yes.
good. Just checking. Okay.
Yeah.
Let's take a look. We have time for a few questions. I don't know how many we will get to here, but let me take a look. Questions.
While Steve is looking at that, we do have a slide that will be coming up here at the end that does have some contact information for Steve if you'd like to reach out and speak with him a little more, or if you'd like to speak with one of the account execs here at TriTech, some contact information for both Brenda and Tyler that will be coming up here in a little bit. We'll give Steve a minute to get through these questions here. We definitely want to thank him for presenting today. This is a topic that
here's a question. With the push for the new model, what will happen to EMS in states like Ohio and other states where community paramedicine legislation isn't moving forward? Well, you know, you just need to be creative, and I would encourage you to really push to move legislation within your states that make for a lot of flexibility to allow your local community, your local medical directors to be able to implement community paramedic programs. It's going to require a lot of, you know, legislative relationships here, and that's something that can certainly help. Minnesota, they did a great job. They got legislation that included reimbursement under the Medicaid program. It's not by coincidence that Minnesota has a full-time an EMS lobbyist who works in the state legislature there. So those kinds of things can be helpful. And you know, still, even without the legislation, there's, I think, a lot of opportunities you'll have to be creative and look at other ways of providing new revenue streams. Okay. Do we have a time frame as to when the quality measurements for higher payments are going to take place? I wish it was higher payments, but in terms of quality metrics and value-based reimbursement, you know, the government's set some targets, and I suspect, and we know we're going to see this happen in the traditional healthcare, the hospital environment first, okay? And I think it's going to trickle down to EMS then after that. So it's probably a few years out before we see the shift from the fee-for-service model of reimbursement. So yes, I think for a few years we're still going to get paid based on the medically necessary transport model, okay? And yes, that's counterintuitive to the way things are going. But I think, like anything, we're not the biggest potato in the field of Medicare. So we're going to be down the list in terms of these changes. Okay, let's see. Does your compliance officer have to be certified? That's a very good question. They should be. That's why NAC offers the Certified Ambulance Compliance Officer program. And there are specific standards of what a compliance officer should do as a compliance officer. Those are already outlined in some of the government's documents. The OIG has put out a couple of compliance documents, one in 1998, a compliance program guidance for third-party medical billing companies, and then in 2003, they published compliance program guidance for ambulance suppliers. So, and in there, they talk about qualifications of the compliance officer and what that person should do. But I think in the future, certifications are going to be key. And as this whole area of compliance evolves, the market right now for compliance officers is very high. If you pick up any healthcare publication, you see tons of ads for, compliance officers, particularly those who've been certified. There's a great need for that as we move forward in this new healthcare realm. So, okay, I think that's about it. We didn't have too many questions on the queue here, and we did go a little bit over. I think I pretty well answered those. Any questions you guys want to hit there that are directed toward you?
No, I think that we're pretty much through those. We'll go ahead and wrap it up then, Steve, if you're okay with that.
Sure. Okay, great. Well, just from our standpoint, Paige, Wolford, and Wirth, I want to thank the folks at TriTech. They do a marvelous job of organizing these webinars as a free service to their customers and friends, and it's a tremendous resource for all of you, and we appreciate so much being a part of that. And we thank you for your participation, and we thank you for all your service that you performed throughout the year, particularly last week, EMS Week, at the time to celebrate what we do in our communities, and my hat's off to you for all the good work that you do. And on behalf of all of us here at Paige, Wolford, and Wirth, we thank you for joining us, and thanks TriTech for sponsoring today's webinar. I'm Steve Worth, and I'll be signing off.
Absolutely. Thank you again, Steve. And I want to join with Steve in thanking you guys for attending today's webinar. We welcome your feedback and suggestions for other topics that you'd like to hear about. You can always email suggestions to webinars@tritech.com. Everyone, have a great afternoon.
Take care, everyone. Be safe out there. Bye now.